right, hello everyone. Thanks for having me. Today I'll talk to you about a case seen this past year. Listen to your heart. So in clinic, we had a 70-year-old woman present with 2 weeks of double vision and a red eye. She was initially seen an outside ophthalmologist, started on some polytrim for presumed bacterial conjunctivitis. Though that wasn't working after a couple of days, so I switched to Vigamox. And at that point, still wasn't quite getting better. I had some erythromycin ointment, and all this while, she still had this double vision, and she came to us to figure out, well, what's going on? So a little bit more, she had this, it was binocular horizontal double vision, and as we mentioned, that red eye that was injected, and maybe a little bit of bulging recently, the past couple of days. No other symptoms. She did have a mild headache, but otherwise no visual acuity changes, no eye pain, and medical history was really unremarkable. On exam, she had 20/20 vision in the right, 20/25 in the left. Pressures were good, no APD, full fields. Color was good. Did have a little bit of proptosis though, about 3 millimeters in the left eye. So here's her exam.
Look up and to the left. Look way up high. Look up and to the right. Look way over to the right. Good. I'm going to get really close to you here. Look down to the right. Straight down towards your feet. Down to the left. Straight ahead.
So on exam, you can see that left eye certainly is a little injected. The conjunctival vessels are a little bit tortuous, chemosis there, and a little bit of lid edema as well. Strabismus exam showed impaired abduction of the left lateral rectus, and also an esotropia that was worse in left gaze, consistent with a left palsy. MRI that she revealed that there was that that proptosis, the left bulb, and also the left medial rectus was enlarged. Now she came in with these images already, and the presumed diagnosis was idiopathic orbital inflammatory syndrome. However, it just didn't quite put together as you would expect to have some pain with eye movements, and also other considerations, or maybe thyroid eye disease, but they didn't quite fit the picture, and her thyroid labs are normal. Orbital cellulitis doesn't present in this time course over smoldering over weeks, and so we thought there was some key piece of the history that we needed to obtain, and so we questioned her a little bit more thoroughly.
Just a loud whoosh in my left ear.
And it kind of comes and goes.
It comes and goes now, and it matches my heart rate.
Got it.
So with this additional piece of information, we went ahead and got a MRA, and here you can see that you have some hyperintense arterial flow into the left cavernous sinus near the internal carotid artery. Further, in this different section on this axial view, she has arterialization of the left superior ophthalmic vein. With this, she was referred to interventional radiology, and cerebral arteriogram did confirm the diagnosis of carotid cavernous fistula. She underwent coiling and had improvement of her double vision, and the palsy was resolving, and her pulsed tinnitus resolved. So just briefly, there's different types of the carotid cavernous fistulas. You have direct and indirect. Direct is usually caused by trauma. It's high flow shunts. In this case, this was spontaneous, and there's dural shunt. It's more from the meningeal branches from the internal carotid artery into the cavernous sinus. There's the classic triad of the proptosis, chemosis, and pulsed tinnitus, and this you can get from the history. And you can really see any kind of full range of signs on exam, from vision loss, anterior segment changes from the chemosis and the conjunctivalization of vessels, or the arterialization of vessels. Also, in the fundus exam, you can also have a lot of venous stasis findings, which in this case do not have. Workup is the MRI, and the classic picture you would see would be that arterialization of the superior ophthalmic vein. Treatment is the coiling. However, in the indirect or the spontaneous ones, up to 50% can resolve with monitoring, and so it's important that they get referred to the interventional radiology for proper management. Thank you.